The author does not have any financial interest in this video. Bullous keratopathy is a commonly encountered pathology in the OPD. Less frequently, the patient presents in early stage with no stromal scarring, good view of antechamber, and normal functioning pupil. Rather, more commonly, they present either with stromal scarring obscuring the view of antechamber, eccentric pupil, atrophic iris, fixed dilated pupil, subluxated IOL, or either combination of above. So, this is a case of 65-year-old male diagnosed with left eye pseudophakic bullous keratopathy, having a visual acuity of counting finger at 2 meters. The patient had a poor view of antechamber, associated peripheral antesynechiae from 3 o'clock to 9 o'clock hour, and fixed mid-dilated pupil. The patient was planned for Descemet membrane endothelial keratoplasty. Epithelial stripping is performed using scraper to improve the view of antechamber. Centration is marked and 7 mm marking is done using caliper. Using 2.8 mm keratome is made. Viscoelastic is injected to inflate the antechamber. Iris repositor is used to break the anterior synechiae. Maneuvering of the instrument to break the synechiae is done in such a way so that there is minimal stretch at the root of the iris so as to prevent iridodialysis and bleeding from the angles. Visco wash is performed. 0.2% pilocarpine is injected to bring down the pupil size. Peripheral iridotomy is made at 6 o'clock using the cutter. Visco wash is performed. A standard protocol is followed to make a 7 mm DMEK graft. Graft is then loaded using the injector prepared from the IL cartridge. Gentle taps are made using 27 gauge cannula to unfold the graft in correct orientation and center it. Intermittently, the antechamber is shallowed to prevent the re-scrolling of the graft. After ensuring the correct orientation and centration, air is injected in the antechamber to fix the graft. Antibiotic drops are instilled and BCL is applied. On post-op day 1, the graft appeared to be well attached as confirmed on ASOCT. At 1 week post-op, the cornea appeared clear and compact and vision improved to 20/60. Since every case of pseudophakic bullous keratopathy is unique in its own way, a careful pre-op planning is needed. In chronic cases of bullous keratopathy, the maneuvering inside the antechamber should be as gentle as possible to avoid antechamber bleeding, which can make the surgery more challenging. Also, it is imperative to counsel the patient regarding the expectations and the outcomes of surgery for better compliance with the postoperative care.